so reasonable drugs can be performed in advance. This is a video of when the brown room was created. Now that we have two monitors, we can block two patients simultaneously. I am involved in several academic society activities. I am currently serving as the Director of Planning of the Korean Society of Regional Anesthesia. From August 28 to 30 next year, the last weekend of August, Austria PM 2026 will be held together with the annual meeting of the KSRA. We would greatly appreciate your interest and participation. Please. Today, I'll be talking about opioid-sparing anesthesia. Discussing opioid-sparing anesthesia in full detail would require a significant amount of time. So instead, I will focus on what is important to reduce the use of opioids in patients and how we are managing OSA, particularly in pediatric orthopedic surgeries at ANC. I have no COI. There seems to be a certain trend even in anesthetic management, from traditional opioid-based anesthesia, which relies on opioids as the mainstay of pain control. The field has gradually shifted towards reducing opioid use, eventually giving rise to the more radical concept of opioid-free anesthesia. It seems that the current trend has shifted towards the concept of opioid-sparing anesthesia, which aims to minimize the use of opioids. The IASP defined pain as unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential teeth damage. The unpleasant sensory component can be considered physical pain, while the emotional component can be regarded as mental pain, meaning both body and mind are in distress. Opioid administration can alleviate these unpleasant sensations and emotions caused by pain. Conversely, while opioids can also be used to ease hardship and suffering, their administration carries the risk of progressing to dependence. Thus, opioids inherently possess two faces, right and shadow, offering both relief and potential harm. As far as I know, the event that could be considered the beginning of opioid-based anesthesia was reported in the ABJM. It started when the attending anesthesiologist instructed the resident to give 10, meaning 10 milligrams, but the resident mistakenly administered 10 milliliters, 100 milligrams. After administration, they noticed that the patient's vital signs remained stable during surgery, making anesthesia management much easier. Following this instance, anesthetic management based on opioids gradually became widely adopted. Have you ever heard of an organization called SOFA? It is an extreme group that advocates for the complete elimination of opioid use and is led not by physicians but by nurses. This society promotes opioid-free anesthesia by stating that opioid-free anesthesia is a safer option for anesthesia administration that maximizes a patient's respiratory ability and aggressively treats their pain while eliminating the unwanted side effects of opioids. The amount of opioid administered is adjusted according to the level of pain. However, after a certain period of use, tolerance can develop, meaning higher doses of opioids may be required. Excessive opioid use is also known to potentially cause opioid-induced hyperagicemia. If both circle together, the graph would look like this. OIH is well-documented phenomenon. Importantly, fentanyl, one of the most commonly used opioids during surgery, has also been reported to induce OIH, particularly when administered at high doses. According to the 2016 review article in Anesthesia, intraoperative fentanyl infusion rates exceeding 0.25 microgram per kilogram per minute are associated with increased post-operative opioid consumption, indicative of tolerance. Furthermore, infusion rates above 0.2 are characterized by reduced mechanical pressure, cold, and pain thresholds, suggesting the development of hyperalgesia. Errors, as is well recognized, highlights that minimizing pain and reduced opioid use promote recovery, leading to fewer perioperative complications and shorter hospital stay. In fact, the biggest issue has been the opioid crisis in the United States. Opioid misuse has become a major social problem, and it is still ongoing. Korea is not an exception. On average, 50 opioid-related arrests are made each day. And in adolescents, the actual prevalence is thought to be 30 to 100 times higher than reported. Opioid dependence can develop even in the presence of organic pain. The risk increases from day 5 after initiation. For post-operative pain, oral opioids prescribed for 3 days are usually sufficient. However, prescribed oral opioids after surgery are often diverted, becoming a major source of problems. Therefore, surplus opioids should be corrected and disposed of appropriately. Receiving a provider's prescribed opioids before the 12th grade is independently associated with a 33% increase in the risk of non-medical opioid use by the age of 23 years. From the perspective of those advocating for OFA, the following arguments are made. OFA is a form of multimodal anesthesia that combines various drugs and or techniques, providing high-quality general anesthesia without the use of opioids. Since multiple mediators are involved in nosection pathway, the anti-nosection required during general anesthesia can be achieved without relying solely on opioids. In perioperative management, OFA has the potential to reduce opioid-related adverse effects. However, recent opinions are generally as follows. OFA should not be performed if the primary goal is simply to relieve postoperative pain and reduce opioid use. It may be considered inpatient and high risk for PO and B. Adequate measures must be in place to manage advising adverse effects associated with opioid alternatives. At present, the application of OFA should be approached with caution. Opioid-free anesthesia may be feasible, but it is neither risky nor beneficial to patients. In 2018, an extraordinary study called the OFA trial was conducted in France, involving 400 patients undergoing elective intermediate or major non-cardiac surgery. How it managed to pass IRB approval remains unclear, but it was nevertheless carried out. The results were published in 2021. Patients received the standard balanced anesthesia characterized by lidocaine and ketamine, and were randomized to either a fentanyl group or a dexmedetomidine opioid-free anesthesia group. Post-operative hypoxemia was observed more frequently in OFA group. Most importantly, the OFA group using dexmedetomidine was associated with severe bradycardia, which ultimately led to the early termination of the trial. Even in the anesthesiology editorial, it was stated that opioid-free anesthesia may be feasible. Nevertheless, it appears neither logical nor beneficial to patients. In the 2021 anesthesiology review, the following advice was given concerning perioperative operative use. Effective perioperative pain management is not only an ethical necessity but also essential for reducing both short and long-term complications and understanding universally acknowledged. The term OFA, which may lead to misconception of completely avoiding opioid use during the pediatric period, should not be used. Instead, based on appropriate evidence, the terminology should shift away from OFA and promote the concept of opioid-sparing anesthesia. The key is to focus on minimizing opioid use with safe and feasible options already established, tailored to each patient's needs. Within OSA, important elements include patient education, minimizing opioid use preoperatively, employing multimodal anesthesia technique intraoperatively, implementing individualized post-operative pain management strategies upon awakening, and avoiding unnecessary opioid use after surgery. Then, what are the risk factors for persistent opioid use after surgery? Most patients are first exposed to opioid during surgery. In pediatric patients, exposure to opioids may increase the risk of misuse later in life. In the previous slide, it was reported in NEJM as follows. Receiving a provider prescribed opioid before the 12th grade is independently associated with a 33% increase in the risk of non-medical opioid use by the age of 23 years. Even just a few days of use can open the door to physical dependence. And once it extends beyond a few months, the risk of developing a behavioral use disorder rises quickly. One of the major causes of opioid misuse is the administration of opioids during the perioperative period. Most previous studies on post-operative opioid prescriptions have been retrospective, but 2023 May, a prospective multi-center study was published. What has already been well established is that perioperative exposure to opioids is a risk factor for persistent opioid use. This new study found that preoperative opioid use was the strongest predictor of opioid use at 3 months. At the 3 months mark, patients who had received opioid preoperatively were 18 times more likely to still be using them. What I found most striking was that intraoperative opioid administration shows no significant association. As for ongoing pain at 3 months, the main factors were patients who had pain preoperatively and by procedural time. The highest risk was seen in mastectomy, TKA, and spine surgery. Given that the pediatric brain is relatively vulnerable in its compensatory mechanism, opioid use in pediatric may be associated with a greater risk of opioid dependence. In the 2022 issue of Anesthesiology as well, a history of prior opioid use and young age were identified as risk factors. What about our current situation? To better understand the current status in pediatric patients, we investigated opioid use over a 15-year period in children with supracondyle fracture. This fracture typically occurs between the ages of 2 and 12, and since the surgical method cross-pinning, cross-reduction and pinning is relatively standardized, post-operative pain can be predicted with some constancy. As you can see here, among a total of 33,770 patients, 53% received opioids. What's interesting in my own reaction was only about half used them, whereas pediatric orthopedic surgeons responded as many as half used them. Either way, the fact remains more than half of pediatric patients who were exposed to opioids during the surgical period. This points to a latent risk of misuse in the future. Looking at the opioid uses, the majority were fentanyl, followed by tramadol. Examining the usage trend, the overall amount of opioid use gradually increased. From 2018 onwards, with the ban on tramadol use in children, its use dropped sharply. However, by age group, opioid use also showed an overall increase, while tramadol use clearly declined with the ban. Fentanyl use did not decrease, in fact, it continued to rise. So let's look at the situation in our hospital AMC. This is a case with general anesthesia with IV PCA. Surgical ended at 11 a.m. In the recovery room, fentanyl was administered twice. Upon transfer to the ward, the patient again reported pain. Afterwards, as the IV PCA began to take effect, the patient seemed to improve. This is a case with general anesthesia only. Anesthesia ended at 12:15 o'clock. In the recovery room, fentanyl was administered. In the ward, the patient continued to experience pain. This is a case with a block performed in combination. Block at 3 p.m. and no pain in the recovery room, no pain in the ward, pain reported at 11 p.m. This is another case with a block. Block at 10 a.m. No pain in the recovery room, no pain in the ward, pain reported at 4 p.m. and again at 1 a.m. In my hospital, I reviewed over 900 cases of pediatric orthopedic surgery, analyzing them through one-to-one matching by age, sex, and diagnosis. This represents the mean and standard deviation, while this one shows the median and IQR. The blood group received opioid only once at most, whereas the non-blood group received them about twice. The red line represents the non-blood group, and the blue line represents the blood group. To put this graph simply, it looks like this. It makes me think, if we can just solve this part, then maybe we could avoid using opioid altogether. That's why we now often use dexamethasone in combination. Block at 10:30, no pain in the recovery room, no pain maintained in the ward. Block at 8:30, no pain in the recovery room, course, I also perform traditional epidural blocks and caudal blocks for reducing opioid use. This is an epidural consolidation video for epidural PCA after knee surgery in a pediatric patient. After carefully lumbar counting to place the catheter tip at L23, the needle was inserted at L34. Loss of resistance was confirmed using saline. And posterior dura can be seen being pushed downward by the saline. This is the real-time ultrasound image during catheter insertion through the epidural needle. The catheter tip was visually confirmed at the L23 level. A small amount of saline and air bubbles was injected through the catheter to visualize the tip. The white air bubble sign first appeared at L12 and then at L23. Finally, the catheter tip was confirmed to be located at L23 with adequate spread extending down to L34. This is a caudal block video. The injection volume is adjusted to reach the target level depending on the surgery and individual patient. We inject in 1 cc increments that determine the total volume by observing the real-time spread pattern. Localized spread, epidural space. We investigated this in pediatric patients through a prospective study. For rolling surgery, it was confirmed that far less volume was needed than we previously thought. In fact, reaching the L45 level required only 1 to 2 cc. So now let's briefly summarize. Opioid should be used appropriately when necessary. The term opioid-free anesthesia should be avoided, and instead the term opioid-sparing anesthesia should be adopted. The opioid crisis and epidemic are not problems confined to other countries. In pediatric patients, evidence regarding the impact of opioid exposure is still insufficient, and further research is needed. If possible, it is better to reduce post-operative opioid use. It is time to move away from using opioid analgesia in the pediatric patient, and regional anesthesia give anesthesiologists that opportunity. Thank you for your listening.
Thank you for your educational and comprehensive talk. Can I take a question right now or the after? After. Oh, okay, thank you very much. Okay. Okay. 结束我再一起一起不要省时间。The next speaker is came from Indonesia. Professor PM play the hole, Professor play in the hole. Is a specialist in anesthesiology and intensive care therapy, subspecialist in regional anesthesia at the Chuji Hospital. And Dr. Piempoli is known as one of the 3 pioneers of ultrasound guided technique, and is introduced this technique since 2006. He is also a pioneer in the use of ultrasound in the field of anesthesia and critical care in Indonesia. And Dr. Pilapito, who is currently developing regenerative therapy in the treatment of neuropathic pain, including the application of stem cells and their products. Dr. Pilapito Ho 博士啊，他是麻醉跟重症的监护专科医师哈，也区域麻醉的医师，也是慈济麻醉跟重症的专科医师啊。他是印尼区域麻醉技术发展的pioneer，就是技术引导者哈。他也是印尼麻醉重症监护跟超音波应用的先驱，目前担任的一些重要的职务，目前致力在再生医疗的治疗跟这个神经疼痛方面的一些研究，包括干细胞跟它产物的相关的应用，包括什么外泌体，大家现在很夯的外泌体等等。Let's welcome Dr. Piramidal Ho.
Good morning, Assalamualaikum. Thank you, Mr. Chairman, for the introduction. My name is Priyamoda. It's quite difficult to pronounce it because it's come from Sanskrit name. Maybe our friend from India can spell very well because we share the same Sanskrit. And I come from Jakarta, Indonesia. I'm working in Ciptomangunkusumo General Hospital, the top level hospital in Indonesia. And today I would like to thank you, Dr. Yuangli, and also all the committee for inviting me and talking about the spinal anesthesia negotiated, focusing about the thoracic spinal anesthesia and combined between GA and the spinal anesthesia. I have nothing to disclose you, and let's start the slide. We know that spinal anesthesia is a long story. Dr. Chipas told us that about us 124 years, yeah? And it started from Dr. Connie and Agus Bier, and at that time, local anesthesia is not common for other type of technique besides the topical anesthesia for iron infiltration. Nobody do the spinal anesthesia before then. But what we know about spinal anesthesia, that we inject the anesthesia in the subarachnoid space, and we'd like to put the needle below the artery level, and why, and I will explain why. And also, this is the main cause. Because we want to avoid the spinal cord trauma if we choose the higher level than L3 to do this kind of technique. And it's study from the principle from Reynolds that's reported. They do the puncture at L2-3 interspace level, and they found 7 neurological damage following spinal CSA because of this traumatic appendular spinal. And that's why the puncture level is now more popular below the level of L3. However, long time ago, Thomas Jonesco, he claimed that if you do the puncture at upper dorsal at T1, T2, and also dorsal lumbar at L1, L2, quite high is it? And he done for more than 1,000 cases, and he claimed that it's useful for all type of injury from the head to toe, without death and without any serious complication. And during answer, all patients retain full consciousness. It's very, very well for us now. But since it was leaving behind, because since the General Society Surgery meeting in 1909, the professor said that it should be forbidden because it's very dangerous. And since then, we are now ready to do spinal anesthesia above the level of R3. This is one. And also we are afraid that the spinal spread of the anesthesia can cause the spinal and total spinal cord. So this is what we know that the traditional indication for spinal anesthesia for all surgery or procedures below the diaphragm. And also we know that spinal anesthesia is best for short procedures if you are not using the catheters. And we also know that the catheter for spinal is very rare using because other complication. So one-shot anesthesia is best for only for the short procedures. These are the contraindications, and we don't also know about it. And now there are some newer indications for spinal anesthesia. First is for laparoscopic surgery. Why? It is known that maybe GA is traditionally first option for anesthesia for this kind of surgery, but there are two articles from Shanghai and Illinois that told us that they do the single scientific with spinal anesthesia without GA. They do a lumbar thoracic spinal for this surgery of lap cholecystectomy, and they find that it's good, and it's not have not quality, not below the GA. However, Andre Van Zundert is the founder of Estra, and I think he posted the case report here that he's done one case of thoracic spinal anesthesia. Why? Because the patient was in the very high risk for GA. The patient will undergo lap cholecystectomy with severe obstructive lung disease and severe emphysema. If we do the GA, it will compromise with the problem of lung, and also have several functional impairment. Even minimal activity is cause her with dyspnea. That's why we do the drug with the GSA technique, but only the spinal drug is given. The epidural is just standby. And we found that this technique also good for this kind of person who is in the high risk for GA. However, he said that the option of the choosing of the patient must be assessed very carefully, and this technique should be made. The thoracic spinal anesthesia should be managed by the anesthetist with considerably experience of regional anesthesia. So it's not for every anesthetist that allowed to do the thoracic spinal anesthesia. So technically, can we do thoracic spinal anesthesia? Yes, because some space is there. There are some distance between the medullospinal and the dura mater. This is the study from Imbeloni in 2008 and 2010. It tells us that in the middle of thoracic, at T5, T6, there's more distance compared to the other part of thoracic. It's about 5 to 7 millimeters. So there's quite some distance. That's enough for us to insert the spinal needle there without injuring the spinal needle. And this distance also increases when the patient put into the sitting position compared to supine and lateral position. We see that in T6, the distance in sitting position is 5 compared to supine is 2, and the lateral position is 4. So yes, there is some space there to insert the needle, but still, the thoracic spinal anesthesia is a feasible option other than GA. However, we have to pay full consideration during the surgery if you do only the spinal without GA, whether the patient got the adequate of ventilation, because we know the laparoscopic will give inserted the gas in abdominally, and the high pressure there, hard pressure there can compromise the ventilation of the patient, and also possibility of the shoulder pain and patient's comfort when the patient putting into head-down position. That's why this kind of technique maybe have to be careful. Some systematic review by Longo said that yes, spinal in laparoscopic cholecystectomy can be used, but may not offer an extra benefit compared with other technique. More shoulder pain and conversion is 3.2% to GA, but it can give best postural patient, and also incidence of PDPH is higher. So, if you want to do the thoracic spinal anesthesia, we need teamwork which is very excellent. Why? Not only does anesthesiologist have to have the good hand, so he can put the needle very precisely without damaging the spinal cord, but also the other part of the team, the surgeon, he has to know. He cannot do the operation longer than the time needed for spinal anesthesia to be finished. And also the nurse and other supporting staff in the OT, they have to know what we are doing and how, if something wrong is happening. So TSI is possible, but choosing the patient and having the good team is very important. So can we do the thoracic spinal anesthesia for routine? There are some articles, but most of them say that, wait a minute, for certain cases, for high risk patient in GA, yes, but for routine, only these three articles supporting the others. Because if we are encouraging everybody and encouraging all the anesthesiologists to do so, just imagine maybe some have good hands, but the other may not have. We can imagine maybe some accidents can be there. Even a single case with trauma, it can cause a big, too much cost for this technique. So, for the patient with a high risk condition, there is never the right way to anesthetize. But if you're choosing between the thoracic spinal anesthesia, we also have to consider, isn't there any more technique that can do for this type of surgery which is more safer? For instance, we can do the epidural thoracic is more safer. Or we can do combine the GA with the spinal, while spinal we do it in the lumbar. And we extend the level of blockage until thoracic, and it can affect the same result with the more safe condition for the patient. So, but when will be when? Yeah, we'd like to play with danger, but let's see in the future whether it will be adapted for routine or not. We just wait for the data, but until now, the data is not cannot support it for routine use for the thoracic spinal anesthesia. Now, the new indication for spinal surgery is for spinal anesthesia is for spine surgery as a single technique without GA. There are some study from ERLAS 2015 involving almost 500 surgeries. He said that the incidence of hypertension and arterial was much lesser than compared with GA. Include the patient with degenerative spinal disorders, so there is no problem for this kind of patient. And conversion, but putting the patient to in the prone position with spinal anesthesia may come if something happens, then we have to convert with GA. But there are meta-analyses, at least 3 of them, that told us there's no report or morbidity or no mortality for spinal anesthesia alone in spine surgery, and all of them told us that it is provide good less blood loss and also less hypertension in the OR and less comfy and less time in PQ and also less time of stay in the hospital. But they do put some barriers there. They just put some algorithm there to keep the patient still safe. So they don't use awake spinal for spine surgery if the surgery is involving more than 2 vertebrae. If the surgeon is a slow surgeon, they don't use it. So yes, there are some more tumor indication, but still there are barriers for us. There are algorithm to keep the patient safe and to keep the procedure still on the right track. So they develop prototype something else. And I hope the one who developed the thoracic spinal anesthesia will also build this. Again, team roles is very important. We also do the spinal anesthesia alone for PCRL in our hospitals as we do it, because we know our surgeon is very quick. Less than 2 hours, the surgery is finished. That's why we do it. If your surgeon will do it in more than 2 hours, don't do it, just do it. Okay, now combine GA and spinal. Long time ago, no, it's not more likely. Most of us say that spinal is one pole, then GA is one pole. But not now. You see GA and spinal now because we can blend it together with a good result for the patient. Why? First time because for laparoscopic surgery, maybe epidural cannot give more benefit, and maybe it's too much for this kind of surgery. And some say that it is correlated with the more motor block and slower rehabilitation for patient. So epidural maybe will be left alone for the laparoscopic surgery. But what is the replacement? Some of the recommendations said that spinal with low opiates as adjunct to GA can give a strong recommendation because it can produce good analgesic post-operatively. But combine it also with the local anesthetic, not only give advantage post-operatively, but also with advantage intraoperatively. This is a study from Levi, combined with local anesthetic and opioid intrathecally, and it gives best a good analgesic post-operative only paracetamol and minoxidil. Compared with others, maybe they still need opioids. And another study from Levi combined between the epidural, spinal, and PCA, he found that the time to tolerate full diet is shorter in spinal and PCA, while in the epidural, the median times until the nausea and vomiting and the bleeding stop were longer combined with the PCA and spinal. And also the post-operative stay was longer in also in epidural, this is epidural. So that's why maybe for in the day after this, epidural have no longer place in the for laparoscopic surgery. And it is also for epidural complication, it's more than combined with compared with spinal and PCA. And also spinal anesthesia for laparoscopic surgery reduce near adequate response. It reduces the maybe for interleukin production is not different between the control, but for the cortisol and glucose and also for norepinephrine, it produces less by the patient with anesthetic with combine of spinal and the GA. It also showed in this article by Calvo-Soto. Adequate hormone was lower in the break and intraoperative with the spinal combined with epidural. So, intrathecal opioids and GA, some meta-analysis and systematic review show that it can reduce pain score for 20 hours post-operatively, but not significantly different at the second days. So, for 24 hours analgesia, yes, intrathecal morphine can give us a very, very excellent analgesia. And non-restricted even with for the hospital fee and risk of nausea and health combined with other type of analgesia post-operatively. But of course, pruritus is increased. And this is a study from the Dow for spine surgery in pediatric. So the pruritus for adult is for pediatric. Again, the pain score is lower in the intrathecal morphine. Yes, it proves us that the intrathecal morphine can give a good 24-hour post-operative analgesia. Another observational study, almost 500 patients, also showed that the same result. And so, combined GA and spinal can have been studied in a very variety of surgery. from abdominal to cardiac also. And our colleagues in Chiptamang Hospital, he really like to do the combined GA and spinal with local anesthesia and intrathecal opioid, intrathecal morphine for cardiac surgery, but he hasn't compiled that yet. I hope someday he will publish it. And this is our experiences. We also try in this preliminary in a rural area for abdominal surgery with high incision at level of above the umbilical. At this hospital, we don't have the epidural set, so we have to deal with the post-operative pain, especially with this type of incision. We know that it can make patient problem with the post-operative that comes patient to short operate post-operatively. So we try to do the GA and spinal combination, and this is what we got. And based on that, the good pediatric post-operative score, only need paracetamol and only one additional tramadol. The other got a good analgesia for 24 hours. So, combined GSP now for laparoscopy, yes, it can push the epidural side because the indication is same. The regimen, we still variety, and we still more data for evidence of it according to the how many the morphine is and on what is the dose of local anesthesia and other adjuvant that may be needed. And for spinal anesthesia, yes, we cannot forbid it as long as it's applied on the right patient with the right tip. For me, thank you very much for your attention.
We take two elected speakers, wonderful speech. Does anyone have any question for the third two?